Hello everyone and welcome. In this video, we will be discussing regarding dacryoadenitis. Now, question have been asked regarding likely diagnosis of a swelling present on the lateral upper aspect of the orbit and the causes for the same. So, likely diagnosis is swelling of the lacrimal gland, which can be due to inflammation of the gland known as dacryoadenitis, or it can be because of a tumor. Dacryoadenitis is inflammation of your lacrimal gland. It can be either acute or chronic, occurs majorly due to infection, inflammation, or some systemic disease. Typical presentation would be a painful swelling which is present on the upper outer quadrant of your orbit, that is near your lacrimal gland. Now, first, acute dacryoadenitis. Acute dacryoadenitis is due to infectious causes, in which it can be a viral infection, which is the most common cause for dacryoadenitis. Viral infection by mumps or Epstein-Barr virus or a cytomegalovirus or herpes simplex or varicella zoster virus. Then it can be bacterial infection. Bacterial infection is commonly by Staph aureus, Streptococcus pneumoniae and Neisseria gonorrhea, which may be associated by sinusitis, conjunctivitis or systemic infections. Fungal infections can occur but they are rare. Clinical features for acute dacryoadenitis are there is sudden onset of pain, redness and swelling, which is seen in the upper outer eyelid. S-shaped ptosis is there, S-shaped as it follows the contour of the lacrimal gland. There will be tenderness over the lacrimal gland, conjunctival chemosis and injection might be present. Fever, malaise and preauricular lymphadenopathy may be seen in these patients. In cases of bacterial infections, a purulent discharge is at times present. On clinical examination, when you inspect and palpate the gland will be swollen, it would be tender. Slit lamp examination is done to check for conjunctival involvement. Ocular motility assessment should be done in these cases because in severe cases, eye movements are restricted. In investigations, you will go for a CBC. In bacterial infection, TLC is raised. Serological test for Epstein-Barr or cytomegalovirus can be done. Lacrimal gland imaging like ultrasound to assess enlargement of the gland, MRI and CT orbit can be done to rule out abscesses. Gram stain and culture sensitivity is sent if purulent discharge is present and you're suspecting a bacterial etiology. So management includes first is supportive care, which is mainly for viral causes, warm compresses, pain relief by NSAIDs or acetaminophen, and adequate hydration is sufficient in majority of the viral cases. In bacterial, empirical antibiotics should be given. Orally, you can go for amoxiclav or cephalexin. Severe cases, you should go with IV antibiotics. In that case, you can give ceftriaxone plus vancomycin. If there is an abscess formation, then surgical drainage is the option. Complications which can occur because of acute dacryoadenitis are it can lead to abscess formation, it can lead to preseptal or orbital cellulitis, can cause chronic dry eye disease if gland function is impaired due to the disease. In severe cases, and if there is an orbital spread, it can lead to vision loss as well. Prognosis usually is good. Acute viral dacryoadenitis resolves within 1 to 2 weeks, and bacterial improves with antibiotics, although close monitoring is required for the same. Moving on to chronic dacryoadenitis, this is mostly non-infectious causes. It can be due to inflammatory disorders like sarcoidosis or a thyroid eye disease or IgG4 related disease, or it can be due to autoimmune disease like Sjogren's syndrome, rheumatoid arthritis, or SLE. Chronic infections like TB, syphilis, and leprosy can also lead to chronic dacryoadenitis. Clinical features mostly in chronic dacryoadenitis, it is painless. Gradual enlargement would be present. It may be bilateral if it is due to autoimmune or systemic disease. Associated dry eye symptoms would be seen because of the gland dysfunction like red eye, irritation, grittiness sensations. Minimal tenderness on palpation, and on palpation, gland would be enlarged and firm to touch. Now, diagnosis, investigations, again you will go for a CBC, you will go for autoimmune markers like ANA, rheumatoid factor, IgG4 levels, imaging, ultrasound, CT, MRI, same as acute. In suspected cases of sarcoidosis or a lymphoma or IgG4 disease, you can go for a biopsy. Management includes basically you treat the underlying condition in this. For example, you will give steroid for sarcoidosis and immunosuppressants for autoimmune disorders. Dry eye relief for relieving the dry eye symptoms, you can give artificial tears. Complications that can occur with chronic dacryoadenitis is it can lead to cellulitis, chronic dry eye, and vision loss. Prognosis is Basically, if you do not treat the underlying disease, then it will persist and progress and ultimately lead to complications. Now, for the tumor part, in which the swelling on the lateral upper aspect can be because of a tumor, the tumor can be a benign one, which is pleomorphic adenoma and is the most common one to occur, or it can be a malignant one in which you see either an adenoid cystic carcinoma or a lymphoma. Management would be getting a CT or MRI done to evaluate the extent of the tumor, and then biopsy and surgical excision for a definitive treatment, for which you have to refer the patient to a specialist. That's it for chronic dacryoadenitis. Thank you so much, and I will see you in the next video.